Hi, everyone. This is going to be a quick review to help you prepare for exam one, which covers modules 1, 2, 3, and 4. That's Intro to Mental Health, Legal and Ethical Considerations in Mental Health Nursing, Substance Use Disorder, and Therapeutic Communication. All right, let's get into it. Let's see. You'll want to review anxiety um, and what happens in a community mental health center versus inpatient. And in a community mental health center, there's really like management of symptoms. You're not going to get daily psychotherapy. That would really happen in like a partial hospitalization. You're not going to have constant staff supervision 24/7. That's an inpatient setting. And psychological stabilization is also for inpatient. But if you're having some symptoms, you absolutely could manage those in a community mental health center that you might go to, I don't know, 1 or 2 days a week or 3 days a week or whatever. All right. If someone is grieving the loss of a loved one, a parent or spouse, and they're feeling sad, and um, and they start to ask, do I have depression now? Which is a question that you'll hear. Some people feel that if they're sad for too long, however they define that, that maybe they're developing depression, and that's not the case. And so the nurse would reply that feeling sad does not necessarily mean that you have mental illness. There are expected reactions to experiences that we have. So of course, feeling grief over the death of a loved one is a normal reaction to have. All right, you want to review the term revolving door. The revolving door effect is a result of deinstitutionalization. Clients are admitted more frequently for shorter stays as funding and insurance companies have started shortening the length of stays. People are discharged more quickly. They're less stable, and so they go out and they decompensate and they come back in over and over, and that is the revolving door effect. The new graduate nurse, the basic level of functioning, you will be expected to use effective communication skills. That is a very basic level of functioning for a new grad. Um, you are not going to be prescribing medications, of course, as a nurse, obviously. You're not going to provide clinical supervision, but effective communication skills is an expectation. So review communication skills. We're going to do that a lot during this course and during your psych rotation in clinical. All right, 1950s. Big thing that happened is psychotropic drugs became available for use. Development of psychotropic drugs or drugs used to treat mental illness really began in the 1950s. Um, let's see, if a student is nervous during clinical, they definitely should discuss their feelings with the instructor. You always want to build rapport with a patient before asking personal questions. It would just be awkward if you walked up and all of a sudden asked some personal questions. You have to sort of develop a rapport, which means some level of comfort. Introduce yourself and sort of gauge how that person is feeling and do they want to talk. And of course, the student should consult the instructor about any unexpected or surprising or shocking situations. Um, thinking about the history of nursing and mental health nursing, um, before the age of enlightenment, um, people were put on display for the public's amusement. Um, look how many movies, look how much the entertainment industry still focuses on mental illness, as entertainment. I mean, this is just an ongoing cycle of being fascinated with people who behave differently. And well, I won't get on my soapbox, but I think that's true in a lot of different situations, even beyond mental illness. But that really is a pretty traditional bad behavior that humans have is putting people with mental illness on display for amusement. And that was in the 1700s ish. Okay. In thinking about your values and beliefs, and if they conflict with those of the clients, and how do you talk about that? Let's say a client says, I carry this lucky, I don't know, I have this very lucky pen and I can't do anything without it. Um, Maybe you believe in a lucky pen, maybe you don't. But you just really have to respect the client's belief. It's not a delusion. People do believe in lucky things, right? Rabbit's foot on your keychain or a lucky pen or a lucky tie, or people have a lot of lucky things. Um, but you don't want to get into a debate with the client. You could just say, I I accept that you feel that's lucky. Now let's carry on and go to group and just move on. So you can acknowledge the client's feelings and move on. You don't want to get into a debate. All right. Um, in the 60s, there was a movement to move more treatment away from the hospital and into community based services. So, community mental health centers were really developed in the 60s and started to expand greatly. Um, All right, psychiatric nursing became a requirement in nursing education in 1950, thanks to the National League of Nursing. And it's the National League of Nursing that accredits nursing programs. And that was something that they spearheaded. And that's important for you to know as a piece of history, nursing history. Um, let's see. Make sure you know what the DSM is. The DSM is a book that really helps with interprofessional collaboration. It provides a standardized nomenclature, and a nomenclature means language. So, a standard set of words and language that we use for that mental health professionals can use around the country and around the world, really. So, provides sort of a standard language. It presents defining characteristics that differentiate specific diagnoses. So, the difference between depression and anxiety, and the DSM really talks about some of those defining characteristics. And it also can assist in identifying underlying causes of disorders, such as phobias, traumas, or chemical imbalances, things like that. So that's the DSM. It was the DSM-5. I think I don't know what edition it's on. Um, Maybe it is still 5. I'm not sure, but just know DSM. Um, let's see. If a client is admitted and if they're disruptive, if they're aggressive, if they're yelling, um, you still cannot force medications on them. The nurse can offer prescribed medication, but if the client consistently refuses, um, the client can continue to refuse treatment unless otherwise decided in a court proceeding. So the court can decide that the client is admitted against their will, but that doesn't mean that you can also give them medication against their will. That's a separate court hearing. It's really important for you to understand that. And you can't, even if the client is going to court to figure out continued stay or not, you can't add that in to that hearing. It has to be a separate hearing. So the client can continue to refuse treatment. Um, Remember in level one in Foundations of Nursing where you learned ethical principles such as utilitarianism and non-maleficence and veracity. And remember, I told you to hang on to those ethical principles because you would review them again. Well, here they are again. So what is non-maleficence? It's, do no harm. And what is utilitarianism? It is doing the greatest good for the greatest number of people. So if one person is really aggressive and other clients are complaining, and the nurse, separates the aggressive client for the sake of the rest of the unit, that's utilitarianism, really. It's a theory that bases decisions on the greatest good for the greatest number. So yeah, review all of those ethical principles. There are several questions on them in this exam and on the final. Okay, so what is the biggest right that a client loses if 911 is called and the client is held involuntarily? Um, the client still has a right to confidentiality, still has a right to treatment review and, periodic treatment review, can still choose their providers within the facility they're going to, but they do lose their right to freedom, right? If they're involuntarily admitted, they've lost their right to freedom. That's why we take that very, very seriously. We make sure um, that it really is medically necessary to do that. We just don't take that lightly. Okay, so let's say you complain that somebody is loud and disruptive. Let's say you're in a store, Walgreens, and somebody in there is like not making sense and they're yelling and they're using profanity and maybe they're offensive and maybe they have sort of a strong odor to them. Um, and maybe they even seem a bit paranoid and say, don't trust anybody and everyone's out to get us. Um, could that person be admitted if they're just in the store saying that and sort of walking around and maybe the store manager says, you need to leave the store, you can't talk like that in here, and the person goes stomping out. Could you call the police and could that person be involuntarily admitted? No. He that person is not a danger to themselves or others. Did they offend someone? Maybe. Um, Are they sort of bordering on possibly not being able to care for themselves? Maybe, but they're not a danger to themselves or others at that point. You can stand on the street and yell. You can offend people. You can look disheveled. That doesn't mean that someone's going to scoop you up and involuntarily put you in the hospital. And as long as a client is not a danger to themselves or others, they can leave against medical advice, AMA. So if someone is admitted, um, so let's say someone's admitted voluntarily. Um, I'll tell you this example. I had when I was working in a psych hospital, I had someone come in. Um, a very nice woman, and she said she was so stressed out. She had a couple of very small children and a husband who worked all the time, and she said she was super stressed out, and she looked a little disheveled. She couldn't take it anymore, and she was gonna hurt herself, and she felt suicidal, and she said all the things. And so she was admitted voluntarily. She signed herself in, and then she spent the night, and the next morning, um, she came up to the desk and she said, "This is not the place for me. I needed a rest. I guess I needed a spa. This is not like I need to leave." So, did she have a right to leave AMA? Absolutely. Could we just open the door? No. If someone requests to leave, even if they're voluntary, you have to call the doctor and talk to the doctor about it. And the doctor will ask, are they a danger to themselves? Are they stating that they might hurt themselves? Do they verbalize any suicidal ideation or thoughts? Um, if the answer is no to all that, so of course I spoke to the doctor and I said, yeah, she said she would rather be in a spa. She's denying any thoughts of harming herself or anybody else. She says she has an appointment with her personal psychiatrist and therapist. And so at that point, the doctor said, okay, you can discharge her AMA. Now, if she would have said, "Okay, I need to leave here," but she seemed like she might hurt herself or someone else, then the doctor might have said, "Initiate, a 24-hour hold," and then we would have changed her admission from voluntary to involuntary, and she could be held. So long story short, when a patient requests to leave a locked facility, you can't just get up and open the door. You do have to have a conversation with the doctor about it. If they're voluntary, chances are good they'll be able to leave against medical advice, but still have to have that assessment and that conversation just to make sure that they're not a danger to themselves or others. Because the day before, she said, she was going to hurt herself. So you can imagine, like, what would happen if we did let her go and she did hurt herself, then of course the hospital would be liable. So you got to be very sure about the assessment. All right, and there's a couple questions that sort of um, ask about that similar situation. Um, you want to review ECT, that's electroconvulsive therapy. That does require consent, just as any invasive procedure would. And so the client has to be able to sign for that. No one can sign for that but the client. That's between the client and the doctor, just like a surgery would be. So the client has the right to sign or refuse to sign the consent. No one else has the legal right to sign consent for that. Um, Um, do some review about malpractice and breaching duty and what's considered a breach of duty and what is not. Basically, if the nurse follows um, agency procedures that are consistent with Joint Commission standards, then there's no breach of duty and a malpractice lawsuit would not be successful. But if a nurse does not follow um, agency procedures, for instance, let's say someone hurts themselves uh, during a time that Q 15-minute checks were not done. That is a breach of duty, and that person, whether it's a nurse or an aide, can be sued for malpractice. And because they didn't follow the agency procedures, the agency is not going to protect them. Um, let's see. When a client has a severe mental illness and they're being discharged to a group home, the expectation is that the client will maintain basic stability. And that means not being a danger to themselves or others in the community. Okay. They're not going to have a complete absence of any symptoms. They're not going to have a super high level of functioning. They're not going to have great social skills. That's not realistic. They could be like that client I just talked about in Walgreens who's talking loudly and who's somewhat offensive and who might have a strong odor, or maybe they're walking funny because of their medications. But they're not a danger to themselves or others, and that's appropriate for a group home. When someone is in restraints, priority is making sure the restraints are not causing harm to the client, making sure they're not too tight on someone's wrists or legs or make sure that usually the client is on a one-to-one if they're in restraints because someone has to be sitting right there next to the client, making sure that no harm is being done to the client, no physical harm is being done to the client. Um, your documentation, of course, we've talked about this since the beginning of level one, but your documentation is a legal document. And a lack of documentation is actually a violation of client rights because your documentation, not only does it say everything that you've done for the client, but it also says that all the things um, were done for the client that, in their best interest, such as Q 15-minute checks and a diet that best matches their needs, like a diabetic diet. Um, uh, any treatment for their good and for their protection. Um, that's all documented. And so, if there's a lack of documentation of the benefits of treatment, or treatment options, that's a violation of their rights because everybody has a right to treatment options and the benefits of treatment. Really important that you know that. Cannot stress enough how important your documentation is. So, all right, that's why we just make you do all this documentation in nursing school. All right. You want to review the substance use disorder, different substances, and their withdrawal symptoms and dangers of withdrawal. So, If someone is admitted with alcohol use disorder and they come in at like 2 in the afternoon and they say their last drink was an hour ago, so like 1 o'clock, what time will their withdrawal symptoms um, start? That's really important for you to know because withdrawal from alcohol can be life threatening. And so it's usually less than 8 hours, and the symptoms sort of peak after 24 to 48 hours. So you really need to know these type of things to really protect someone. And yeah, so make sure you know all those, time of onset of withdrawals. So you want to know about different treatments for alcohol addiction and withdrawal. You want to review disulfiram, um, which is something that it's a drug, it's a medication that someone can take every day to deter them from drinking. And if you drink on this drug, um, it results in low blood pressure, headache, sweating, nausea, vomiting. There's really a severe reaction. So it's only going to be prescribed to someone who's already very stable in not drinking. They're stable in their sobriety and they're taking it as an added deterrent. We're not going to give it to someone who's at high risk for drinking because it can be life threatening. And even those symptoms can be dehydrating at the very least and life threatening at the most. It's important to realize that relapse is part of addiction and it's a normal part of addiction. And so when people are admitted because they've relapsed, they tend to feel shame. And, we don't want to focus on that. We want to help someone through that. And so we would really just ask, like, tell me what happened since your last admission. So we're not going to like focus on like, oh, you shouldn't feel bad or whatever. We're not navigating their feelings there. We're just going to be very matter of fact and like, let's figure this out. Let's figure out what happened. What was the trigger? What can we do differently this time? And you're supportive and trying to figure it out. Be on the client's side. Um, and that's really important to remember when you're talking to coworkers also, because you might have a coworker when you're working in a substance use facility. You might have a coworker who makes a comment like, "Oh my gosh, they're being admitted again." You can acknowledge like, yeah, this can be frustrating, and remember that relapse is a part of addiction. So you want to review Alcoholics Anonymous and what are the principles? The principle is the norm is sobriety. They want complete abstinence. It's important to realize that. Again, alcohol withdrawal can be life-threatening, so it's not safe for someone to stop drinking without supervision. Um, when we're talking about withdrawal, um, you really want to remember a lot of your med surge principles, a lot of the physiological principles that you've learned. Don't let that stuff leave your mind just because you're in a mental health class. It's very relevant. So if you think about fluid volume deficit, what would you expect to see in the vital signs? In someone's skin turgor? Um, we are very concerned with fluid volume deficit for the person who's on lithium, which we haven't talked about yet. We'll get to that a little bit later in the course, but who's on lithium and who is outside in the hot sun all day. Um, fluid volume deficit is if somebody is in withdrawals and they're throwing up or they have diarrhea. So yeah, so don't let your med surge brain turn off. All right, let's see. What is the danger of overdose on barbiturates and opiates? Respiratory function. Um, what drugs are frequently used for alcohol withdrawal? Benzodiazepines are frequently used. What supplements are prescribed for someone who might be experiencing Wernicke's encephalopathy, and you will want to look that up. You want to know, we call it a banana bag in the emergency room, but what is in that bag and what do we give someone withdrawing from alcohol? What do we give them every day? What supplements? You need to know that. So I'll leave that to you to look up. I believe it's around slide 22. It's in Vitabec and it's also in the PowerPoint. Look up tolerance and know what that term means. You also want to look up codependency and understand what that term means. A red flag for codependency is maybe family members blaming themselves for the problems that someone else is having. Going back to AA and 12-step programs, you need to have an understanding of like how they're run. They are self-help groups and they are not run by health professionals as leaders. They're really run by other addicts. It's a support group and self-help group. Let's see. So getting into communication skills, you want to know what a broad opening is. If someone is really kind of fearful and reluctant to talk, you might use a broad opening, like, what would you like to talk about today? That's pretty broad opening. You want to stay away from closed questions. Closed questions are yes or no questions. So you want to really ask people to describe something instead of yes or no answers. If you ask a yes or no question, you're only going to get a yes or no as an answer. So you really want to sort of make an observation like, hey, you look like you're deep in thought. Can you describe what you're thinking about or what you're feeling? Um, then someone will really verbalize what's going on with them. Um, you want to really review those communication skills. You will need to know those for this exam. What's an example of restating? So that is, if somebody says something in their statement, if they say something and you restate it in sort of a different um, way, it's restating. Like, it's Gosh, I haven't seen my family in so long. And the nurse says, you haven't seen your family in a while? That's restating. It's not parroting, so you didn't parrot back exactly word for word, but you did restate. Um, so yeah, you want to really review restating, review exploring, review your observation skills, and you should know what assertive communication is. So, assertive communication is using I statements. Um, when you yell, I feel afraid. Um, that's assertive communication. It's not, it's not like, don't do that to me, or, because that's really a you statement. But it's really just talking about me. I don't know. When you're late, I feel insulted. That's assertive communication. You'll always know it because there's an I statement. You want to know um, appropriate distancing. So, a nurse client distance is about 3 to 6 feet. An intimate distance would be like a small child sitting on a mom's lap. Um, but there's personal distance, there's professional distance. Of course, there's, broader distance, like when someone talks to an audience. But the nurse client distance, professional distance is about 3 to 6 feet, about arm's length. Um, like if, yeah, about arm's length. You have to respect clients, their beliefs, religious, spiritual. If you don't, there really won't be any trust being formed. You really need clients to trust you. In every setting, not just mental health, but especially in mental health. Otherwise, they're not going to take medications from you. They're not going to talk to you. If they don't trust you, I mean, you know that just from your personal life. If someone doesn't trust you, if you don't trust someone, you're certainly not telling them anything, and that's not going to be very helpful in a mental health setting. So you have to respect people, and you have to work to establish some level of trust. All right, I think that's about it. Feel free to reach out with any questions. Um, that's all I have.